This is called I Got a Kidney Transplant. Now what? My name is Dr. Divya Jain Decker, and I'm a transplant nephrologist at Loyola. And I thought for a lot of people, especially when you don't know what to do after you've gotten that kidney, how to maintain it, this could be pretty useful. So first of all, kidney transplant, it's not a cure to kidney disease, but it's an effective treatment. And the reason that I say that it's not necessarily a cure for kidney disease is because many times the kidney disease is actually caused by chronic diseases, such as diabetes or hypertension. And when you get a transplant, we're not actually curing the diabetes or the hypertension. So therefore, we're not curing the cause of your kidney disease. But the idea is for it to be a treatment so that you could hopefully avoid any dialysis. Additionally, for some patients, though, it might be a cure for kidney disease, but our medications and whatnot afterwards can cause some diabetes and hypertension, which could actually affect the kidney transplant later on. So, bottom line, regardless of what's going on after you have a kidney transplant, you always still have chronic kidney disease. So why do people get kidney transplants? They get them so that they can get off of dialysis or to possibly live longer. There are some patients who've never been on dialysis that get transplants prior to ever starting it, and that's called a preemptive kidney transplant. So in that case, we're really hoping that not only will you have a mortality benefit about living longer, but we also hope that most of our patients will also have a quality of life benefit so that they're living better qualities of lives, doing things that they used to be doing, whether it be grocery shopping, whether it be exercising, and for some patients, maybe even having children. So in this graph right here, basically it's depicting what are the expected remaining lifetimes in years if you're on dialysis versus transplant patients. So the light purple line represents patients who've received transplants, and the darker bluish purple line is showing you patients who are on dialysis. And in every age group, you can see that patients who've had a transplant have a longer expected lifetime compared to that if they were to stay on dialysis. So what are the different types of kidney transplant? We have deceased donor transplants and living donor transplants. So deceased donors are also called cadaver donors. Basically, someone has died and has agreed to become an organ donor prior to their death, and that kidney is donated after death. On average, these kidneys last about 10 years or so. It could be more, it could be less. It really just depends on each patient. There are different types of deceased donor kidneys. One might get a deceased donor kidney from someone who is brain dead. Others might get a deceased donor kidney from someone who died of cardiac death. For the most part, the patient is not going to notice the difference, but your transplant team will keep that in mind with what they expect as far as recovery and creatinine after you've gotten a transplant. Living donor kidneys are a great option for patients if you are able to find a donor. So if you can find a suitable donor, we always prefer for our patients to get living donor transplants. Why? Because on average, they last longer than a deceased donor transplant, but also that kidney never had a lack of blood flow at any point as far as coming from a deceased donor. You know that kidney is healthy when it's coming from a living donor because that donor has to be healthy in order to donate that kidney. And a living donor does not need to be from someone who is related to you. It could be from a friend, it could be from a neighbor, it could be from anybody, it could be from someone you don't even know. People who get kidneys from donors that they don't know that are living donors, those are called altruistic donations. So kidney transplant recipients are more likely to have a working kidney 10 years after transplantation when their kidneys come from living donors than from deceased donors. So again, that whole idea that a living donor kidney should last longer than a deceased donor kidney. So what can you do to keep your kidney from failing? Well, this little cartoon says, frankly, darling, I think your doctor is a little obsessive about this compliance thing. I would have to disagree. I would say that compliance and adherence is one of the biggest things that everyone should obsess about when it comes to maintaining the health of your kidney transplant. So you should know who the players are when it comes to your transplant. The very first player, the most important player when it comes to transplant is going to be you. You're the patient, you're the one with the kidney inside of you, you're the one with the chronic kidney disease, you are the most important player. The transplant surgeon is the one who performed the operation and will manage the surgical issues afterwards. Sometimes some of these surgical issues might include a fluid collection that can occur after the operation. That collection might require intervention with a drain, but it might not. Oftentimes, these things called lymphoseals will reabsorb on their own. It is possible that someone might get a wound infection, and that's going to be treated with the surgeon and the transplant nephrologist in place. And sometimes an infectious disease doctor might need to be involved. And then there are things called ureteral leak, where in which it's actually your urine is leaking out. So the transplant nephrologist, that happens to be what I am. I'm a transplant nephrologist. So I'm a kidney doctor who specializes in the care of kidney transplant patients. So I'm specialized in that. I've specialized in treating your complications from kidney transplant and maintaining your immunosuppression or your anti-rejection medications after transplant. We work with your transplant coordinator, which is usually a nurse who is taking care of basically everything after your transplant. And you want to make sure that if you've received a transplant, that you know who your coordinator is. You should know their full name. You should know the phone number and how to reach them. And you should always know the fax number and keep all of those on you so that if you ever go to other providers and they need information about your transplant center or anything to do with your transplant, you can give them the coordinator's number and then they can get a hold of your coordinator and ask the transplant team what's going on. Transplant pharmacist, very important, reviews your medications, and they look at all the interactions between medications. They also review your medications every time a new medication might be prescribed. So that prescribed medication might not be from the transplant team. It could be from your primary care provider. It could be from your psychiatrist. It could be from anybody. But we have to make sure that we're looking at these medications to make sure that they're not going to interact in a harmful way with your transplant medications. Transplant social worker. So this is someone that'll definitely be evaluating you prior to transplant, and you might still have questions for the social worker after transplant. And so this transplant social worker is going to help with any emotional and social issues that arise, and also a lot of financial issues that come about. The transplant social worker also helps with maybe patient assistance programs as far as medications along with the pharmacist. So basically, they're the ones who are going to look for all the resources for the transplant to succeed. Some patients follow with a transplant dietitian afterwards, especially for my patients who might have uncontrolled diabetes after transplant or weight gain. It's favorable if they can see the dietitian. And then you want to make sure you still have a very good relationship with your local nephrologist, who's your kidney doctor prior to transplantation. That physician will take care of you after your transplant long term. So usually at about 6 months to 1 year, many transplant centers will discharge the patient from the transplant center and have them follow up with their local nephrologist on a more regular basis. And then lastly, you have your primary care provider. And I can't stress that enough. Many patients come to us and I ask them, who is your primary care provider? And they can't tell me at all. Because I think when patients have chronic kidney disease, when you're on dialysis, it's hard sometimes to really make those appointments or keep those appointments with primary care doctors, or your nephrologist might be doing all of that for you. But afterwards, it might be hard for your nephrologist to continue to do all of that for you, especially if they're not seeing you 3 times a week on dialysis. So we really stress that patients establish with a primary care provider, because the primary care provider is also going to take care of things that are not kidney related, such as age appropriate cancer screenings, annual physical exams, anything else that you might need, that's going to come from your primary care provider. So I mentioned adherence and compliance. Those are things that we obsess over as providers and that we also want our patients to obsess over as well. So regarding adherence, it is a proactive behavior in which the patient actively participates in his or her care. For example, when you go to fill or refill your prescriptions, that act of doing it is noted as adherence. Compliance, on the other hand, is a passive behavior. And so the patient will follow the instructions given by the provider. And so taking those medications that you've just filled on the scheduled as prescribed, that is considered somewhat of a passive behavior, but it's still a favorable behavior. And so that means that you're complying with what your providers have directed you to do. Now, if you weren't adherent and compliant to begin with, you would not have received a kidney transplant. That said, even my most adherent and compliant patients sometimes forget that they do still have chronic kidney disease and need to be taking care of themselves because they feel so good and they forget that they need to come to their appointments and continue to ask for refills on their medications. So we ask that you remember to always keep your appointments. Take your medications the way that you are instructed to take them, and always let the team know if there are any problems or issues. So appointments, that is one of the big things that I see for patients that can be really hard to comply with, especially, some patients are great at it because they're like, oh, doc, it'll be easy for me to come to those appointments. I'm used to going to dialysis 3 times a week. Other patients, it can be really hard. You're coming to see the doctor 2 to 3 times a week in the very beginning. That's not an easy task. And when you do that, we ask for blood draws frequently before those appointments, and the appointments can become very long. But the big thing to remember is that this is not something that's going to carry on forever. And you have to remember the long game of it. The long game of it is that you want to maintain that transplant for as long as possible. So in the end, 4 to 6 weeks of coming to your doctor 2 to 3 times a week, it's not that big of a deal if you think about the fact that you want to keep this transplant for years. So after about 4 to 6 weeks, though, those frequent appointments usually decrease to once a week. After about a month or 2 of that, then you'll go to once every 2 weeks, and then it'll taper to once a month. And most transplant centers will continue that taper. And like I said, after about 6 months to a year, you're going to start to then see your local nephrologist regularly. That said, you should still see your transplant center annually. So medications, there's a lot of medications after transplant. Some patients say that it's more medications that they were taking before transplant. For others, there's actually less medications overall. But the most important of those medications are going to be your anti-rejection medications, also known as your immunosuppressants. Some of the immunosuppressants that you might be on tacrolimus or cyclosporin. I've included brand names afterwards. So tacrolimus is also known as Prograf, which is a twice-a-day medication usually, and Varsis, which is a once-a-day medication. And some patients are still on Astigraf, which is also a once-a-day medication. Those 3 are different formulations of tacrolimus. Cyclosporin is also known as Mural, Gengraf, or Sandimmune. Some patients might be on sirolimus or everolimus, known as Rapamune or Zortress, respectively. Then you have another class of medications called your mycophenolic acid medication. So you might be on mycophenolate mofetil, or you might be on mycophenolic acid, mycophenolic sodium. So it's important to know which ones you're on because Cellcept is different than Myfortic. Prednisone is another medication. You could also be on belatacept or leflunomide. These are various types of medications to try and maintain your kidney transplant. On average, patients, as far as immunosuppression go, are usually on 2, maybe 3. If they are on 3, the third one is usually prednisone. So what does it mean that I need to get my level checked, or when the transplant center says, oh, your level was good? What does that mean? Well, many of your medications, your immunosuppression meds, we're monitoring them by checking your drug levels in the blood. And so these drug levels are actually drawn prior to your next scheduled dose. That's why a lot of times I'll call my patients and I'll ask them, like, what time did you take your medication last night or yesterday morning? So then I know based on today's labs how many hours it had been to try and make sure that your drug levels are being run within a therapeutic range. So it's always important to note what time you took your last dose of the medication prior to the blood draw. So other medications that you might be on an antiviral for a few months for prophylaxis. So you might be on valganciclovir or acyclovir. And this is antiviral prophylaxis for certain viruses such as cytomegalovirus, also known as CMV, and herpes simplex virus. We do that because you are quite susceptible after transplant to these certain viruses, which can wreak a lot of havoc, not just on your transplant itself, but also for you. You might also be on an antibiotic to help prevent pneumonia from pneumocystis or PJP. Most patients are on Bactrim. Some patients might be on an antibiotic. If they don't tolerate Bactrim, they might be on Dapsone or atovaquone, or perhaps an inhaled medication known as pentamidine, which is given once a month. The idea is for all of those to prevent this PJP pneumonia. That said, there are too many medications, but in order to maintain your transplant, those medications are necessary to prevent rejection and infections. And Uncle Sam is right. He wants you to take your medications. We want to make sure that your transplant was not done in vain and that it will continue to be working for you years to come. So I get that I'm on these anti-rejection meds, but why am I still on certain other medications? Why am I still on my blood pressure pills? Well, remember, transplant is a treatment, not a cure. And some of our medications, as good as they are for anti-rejection, they can actually worsen some things. So for some patients, some of the medications, such as tacrolimus, which was Prograf or Envarsus or Astigraf, can actually worsen diabetes and cause sugars to be higher than what the patient was used to. In addition, patients might also have worsened diabetes because once you have a functioning kidney transplant, any insulin that might have been hanging around your body when you didn't have working kidneys is now being excreted because your body is very efficient and the kidney doesn't want excess hormones hanging around. So a functioning kidney transplant will excrete any excess insulin, thus making diabetes medication requirements higher. Additionally, some of the anti-rejection medications can worsen your high blood pressure, which is why you're still on high blood pressure pills. We hope that if you have a really good transplant, maybe you won't be on any blood pressure pills or you'd be on less, but there are definitely a handful of patients that end up on more blood pressure pills. Some patients still require some medications for anemia after transplant, but usually if your transplant's functioning fairly well, you won't be receiving those Epogen or Procrit injections or Aranesp injections that some patients are used to getting. Hyperparathyroidism, some patients might have been on Sensipar prior to transplant or calcium supplements, that we watch closely. And again, we hope that it should get better with a functioning kidney transplant, but that's not always the case. And so we pay close attention to your bone labs, so to speak. So the calcium, the PTH, and the vitamin D. Well, how can I remember to take my medications? Pillbox. Pillboxes are fantastic. And the reason I think a pillbox is so useful is because when you have so many types of medications and you're just taking them from the bottle, unless you have a way to separate the bottle as soon as you take the medication from before you take it, pillboxes end up really good so that you don't double some doses in the morning on accident or forget other doses. An alarm to help remind you as to what time to take your medications is extremely useful. You want to make sure you have your medication list and keep that up to date. And then also a calendar. A calendar is really good, especially when you're on maybe like a vitamin D pill that's only once a week or once every 2 weeks. You're going to want a calendar so you know exactly, when you're supposed to take that medication. Maybe write it down on your calendar. So will I ever come off of some of these medications? Possibly. Those antiviral medications that I mentioned, such as Valsite, also known as valganciclovir, or acyclovir, those are prophylaxis. Also the antibiotic for pneumonia, that's also prophylaxis. So we don't usually keep our patients on those forever. but you want to make sure you talk to your transplant nephrologist, transplant center about this. So this little cartoon is a little bit blurry, but the doctor is saying to the patient, so what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? So what can you do to maybe lessen your medication burden? Maintaining a healthy lifestyle can go further for you than you think. Healthy diet, exercise, healthy weight. You want to make sure that you're treating your kidney really well, that, treating it like the gift that it actually is. Adherence and compliance to make sure that you're doing everything you possibly can to keep that kidney going. And please, don't smoke. If you were never a smoker, don't ever pick it up. And if you are a smoker, I would urge you to quit. So what are some of the side effects from kidney transplant? Well, there's increased risk for certain diseases. So I had mentioned high blood pressure and diabetes possibly getting worse. Cardiovascular disease. So cardiovascular disease for kidney patients, it's the #1 killer in any patient with chronic kidney disease and end-stage kidney disease. That risk of dying from cardiovascular disease actually lessens after a kidney transplant. That said, you're still at higher risk compared to the general population for cardiovascular disease. High cholesterol, gout. Gout is possibly due to our medications, such as tacrolimus, Prograf, and Varsis, Astograph. Much more susceptible to infections because when we suppress your immune system with those anti-rejection medications, we are suppressing your ability to fight off infections. And it's important to really make sure that you're keeping up with your lab appointments and doctor's appointments because we are monitoring your drug levels. And the reason we monitor those levels is to make sure you're not over immunosuppressed, that you might be getting infection after infection after infection, but that you're not under immunosuppressed either, where you're at risk for rejection. Additionally, vaccines are very important when it comes to preventing infections. You're also at increased risk for certain diseases of certain cancers. The overall risk for developing cancer is still low after transplant, but there's certain cancers that I'll go through that you would be at increased risk for. So which ones? Skin and lip cancer, you're at increased risk for those. Cancers caused by viruses. So HPV, which is human papilloma virus, causes cervical cancer, can also lead to some of these skin and lip cancers. So it's important that if you are age eligible to get that vaccine, that you actually get that prior to transplantation. Lymphoma, we do see a somewhat increased risk of a post-transplant lymphoma, and that is due to a virus that most Americans have been exposed to, known as Epstein-Barr virus. Some of you might know this Epstein-Barr virus as the virus that causes mono or mononucleosis. Whether or not you recall having mono, you might have already had exposure to Epstein-Barr. And if you've had that, you are at a bit of a risk of lymphoma after transplant, because when we suppress your immune system and we keep you from fighting infections, viruses that might still be in your body, and when you were immunocompetent, those viruses were sleeping or lying dormant in your body. After you've had a transplant and you're on immunosuppression, so you're no longer immunocompetent, but you're immunocompromised, I'd like to say those viruses can have a party in your body or proliferate and grow. And if that happens, sometimes those viruses can lead to these cancers, such as the skin cancers and the lip cancers or lymphomas. So what should you do to try and decrease your risk of developing cancer? Well, the biggest thing is to make sure that you're up to date with all your age-appropriate cancer screenings. So for women, it would be mammograms and pap smears, and for men, prostate cancer screenings. And if you're over the age of 50, making sure you're up to date on your colonoscopy. Additionally, we also recommend that transplant patients should see a dermatologist once a year to have a skin exam to make sure that there's nothing that looks like they could be developing any cancers. You should know that the most common skin cancer after transplant is basal cell, which is actually quite benign. But the problem is once patients get it, sometimes they keep getting it over and over again, and we still need to then reduce your anti-rejection medication. I do encourage my patients to make sure that they wear sunscreen no matter what their race is or what the weather is. And it should be at least an SPF 30. So is it safe for you to get vaccines? Absolutely, but only certain ones. You have to make sure that your providers know that you've received a transplant and that you cannot get any live vaccines. You can only get killed or recombinant vaccines. You should get your flu shot every single year. And you should definitely make sure that you're up to date on your pneumonia vaccine. And remember that there's 2 different types of pneumonia vaccines, so you want to ask your provider if you've received both types. So what about other vaccines? I've listed for you the other vaccines that are fine to get. Tetanus boosters and pertussis, which is the whooping cough shot. You should definitely be making sure to get those. And then I wrote at the bottom Shingrix, which is the recombinant shingles vaccine. So there's actually 2 types of vaccines to prevent shingles or zoster. And so Shingrix is the one that's okay to get. On the other hand, Zostavax, which is the live shingles vaccine, is not one that you should get after transplantation. So what if you want to travel? Well, it's okay to travel, but you should let your transplant center know where you are going. You might need vaccines prior to transplant. You might need medications and refills prior to traveling. Those are all things that you're going to want to make sure that your transplant center knows. I also recommend for my patients that they look and call their health insurance and make sure that wherever they're traveling, especially if they're traveling abroad, God forbid if something happens to them, do they have health insurance coverage in these places? And what is that coverage? And will they be able to come back home? Do they have that? If they don't, then they should maybe consider looking into additional or supplemental health insurance for those trips, known as medical assistance. Because what you don't want is that if you're traveling abroad and something happens to you, that you're at a place where they don't know how to take care of transplant patients. You might be in a small remote area and they don't know how to take care of transplant patients. So you want to know that you can get to a facility that knows how to take care of the patients, can communicate with your transplant center, or possibly be somewhere where you can get repatriated back to your home country. So for some people, they would like to get pregnant after transplant. And this is something that we tell our patients you need to wait at least 1 year after transplantation before you try and family plan. We need to change some of your medications usually after transplant, especially if you're on Cellcept, which is mycophenolate, or Myfortic, which is related to that. Those agents need to be changed prior to getting pregnant. And the reason why is because they are teratogenic, which means that they can cause birth defects or possibly miscarriage. And if you're of childbearing age and you are on those medications, we make our patients sign these forms called REMS forms saying that you will not get pregnant while on those medications. And then you should also be using contraception if you are not postmenopausal. So why might my kidney fail? Well, rejection. It's always on our mind. This is why I tell my patients, I want you to be the most perfect patient possible. I want you to do everything you're supposed to do so that God forbid if a rejection still happens, you're not going to blame yourself, that you should have taken your medications or you should have come to your appointments. You want to make sure that you're doing whatever possible to avoid a rejection. That said, even my most perfect patients, rejection can still happen, but then you're hoping if they were doing everything, maybe that rejection would be mild. Some patients, their immune system just revs up and it's harder to immunosuppress them and prevent rejection compared to some other patients. Additionally, some patients might get recurrence of their original disease. So probably the most common one that we see recur would be diabetes, especially if the diabetes isn't controlled after transplant. That can recur very easily in the transplanted kidney. Other patients, though, might have a glomerulonephritis that could recur in their original kidney. And then lastly, some patients develop new diseases causing kidney disease. So diabetes and high blood pressure, gout, but also the medications. Tacrolimus is one of our best anti-rejection medications, but it does cause wear and tear on the kidney long term. And then if my kidney fails, can I get another? Well, again, if you were a great patient who kept coming to your appointments and taking your medications, it is very possible that you could get another kidney. But for those who might have not been compliant or adherent, I think it's going to be a lot harder. It also depends on what is the reason for your kidney failing. Was it a rejection? Was it a recurrence of disease? How quickly did these things happen? Those are things that the transplant center is going to want to know. So the overall goal, though, is to maintain your kidney transplant as well as you possibly can. Now, I put this slide in here because of what's going on currently. And so in regards to COVID-19, I've had, doctors call and ask, like, what should we be doing? And it's hard in the transplant community because this is a novel disease for all of us, meaning, no one has experience with this. The one thing I can tell you, though, is if you are having a fever, sore throat, shortness of breath, cough, or you know that you were exposed to someone, you need to call your transplant center. If you've had a transplant, your center absolutely needs to know, because it's possible that you might need to decrease some of your anti-rejection medications. Your transplant center is going to want to check up on you every day. If you need to go to the emergency room, they'll guide you with that. Those are the things that your transplant center needs to know. On the other side, if you are listed at a transplant center, you should still let that center know, because if you are active on the wait list and you've been exposed to COVID or you had COVID, you absolutely need to call them, because what you don't want is that you've had that COVID, maybe it's still in your system, because even though you might not have symptoms anymore, you might still be shedding the virus. And if you were to get a transplant, it's possible that you could reactivate the virus. So you should absolutely let your transplant center know if you've had exposure to COVID or you've had COVID, even if you're just listed at that center. Thank you, and please stay safe.